Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast. Hi, everyone. Dr. Eric Westman here, and it's my great pleasure to be able to interview Dr. Rob Cywes. Now, did I pronounce that right?
Yes, you did, but Rob is good enough. My father's Dr. Cywes. I am just me.
So doctor in the family, child of a
Doctor up
doctor.
and down the family. Yeah, yeah.
Well, we'll get into that in just a minute. Now, I've known you for years. We've gone to meetings together, giving talks, and we also are on the board together for the Society of Metabolic Health Practitioners. We might get into that a little later, but I have to say that you're kind of unique, and you've probably been told that before. Tell me how you
Sometimes
got.
in a good way, sometimes not so much.
But you're a bariatric surgeon who's now has the handle Carb Addiction Doc and treats people remotely. And so, how did you get into this? And you have to include your PhD. This, I
Right,
mean,
and yeah, and yes, I am a surgeon. I'm both a board certified pediatric surgeon and a board certified general surgeon. And really, there were two parts that started this. I'm going to take you into the lab when I was in Toronto, and I was working with liver dysfunction, primary non-function in transplanted livers, which was very prevalent, where they reperfuse a liver after transplant, the thing didn't work. And when you biopsied that liver, the sinusoids, which are the blood vessels in the liver, were just clogged with this big blood clot. And the question was why? And what we found is that the endothelium, or the cells lining that blood vessel, were very, very triggered by inflammation. You could measure the inflammatory markers in those vessels, and the inflammation triggered the clot. And the clot led to a fibrin clot, followed by platelets that became activated, followed by white cells that became trapped into that with the Kupffer cells involved. The sinusoids don't get plaque like we do in arteries, but every other element we were seeing, and it started with the inflammation of the vessels. So the first part of my time in the lab, my master's thesis, was done to create a biologic form of inflammation. Now, I'm working in a laboratory where a decade before, they created the glycemic index for the management of diabetes. Okay. And the head of that, who was on my PhD committee, a guy by the name of Dacre Jenkins, is a vegetarian, very low fat, 1981, right, that wrote the Sentinel paper on the glycemic index. So I'm working in a lab, also studying cholesterol, cholesterol gallstones, blaming fat for cholesterol. So I started my research, and we think, okay, let's look at the different things, different drugs and different things that can cause inflammation in the liver. And we were able to isolate a liver in a chamber and put flow through that, keep the liver alive, but test different elements. We tested all kinds of lipids, polyunsaturated, which was in the TPN. We tested saturated fat, nothing. Liver just smiled and loved it. We tested protein.
Fats didn't
That's
cause
no
inflammation.
effect on the liver. Not, in fact, if anything, subdued the inflammatory response. Amino acids subdued the inflammatory response. Whether they were extracts or full immune system, just no response. And a variety of drugs, steroids, things that were used in the transplant process, no major effect, okay? Then we started with dextrose, and everybody knows that you have to have sugar to keep your brain alive. So we used glucose and fructose and galactose. And we actually did it using an insulin clamp. So we maintained the blood sugar, but we had to use insulin. Even though the liver doesn't require insulin to take up sugar, it does require insulin to transform sugar. So we used it under an insulin clamp where we kept the glucose concentration at a good level, but a high volume of carbohydrate going into the perfusate. And what we found, in a dose-specific manner and a substrate-specific manner, fructose the worst, glucose the intermediate, and galactose the least worst, and a concentration dependent, we created the exact injury to the endothelium that we saw in our transplant patients. Then if we sequentially added fibrin, or not fibrin, but non-cellular procoagulants, so FFP, fresh frozen plasma, which has got all the elements to create a clot, but no cells. we created an inflammatory response, a response, a clotting response, intrinsic clotting response. Then we added platelets, and very rapidly the platelets were activated. Then one of my colleagues did their PhD on neutrophils and another one on Kupffer cells. So we had each person in the lab for our PhDs working on a different cellular element. My project was platelets. So we proved that platelets were the transition from the fibrin clot to the cellular clot. And when platelets become activated, they attract all these neutrophils. And I was able to block that with a variety of substrates, the most important one being a thromboxane A2 inhibitor, which is the trigger for, and I know these are big words, but why thromboxane A2? That's what aspirin is. So aspirin is a thromboxane A2 inhibitor, and we could then dissolve the clot using thrombin or antithrombin very easily, which our body is doing all the time. So we proved categorically that sugar was, and we actually used sugar infusion to create the injury that we were then studying the amelioration of. But sugar was the problem. And the issue then, Eric, is that was, nobody could believe my results. So your results are wrong. You're doing the experiment incorrectly. It can't be. And for a decade, I questioned kind of imposter syndrome, that there's no way on God's earth in front of these world's experts that I could possibly be right. And it took me at least a decade, and then going back to look at my research to say, no, I was right. But I had to remove the cognitive dissonance out of that way. And we could glycogenate the liver very easily.
What year would this have been?
This is 1990 to 95.
Yeah, so I was in training, research training, and only got a master's in biochemistry. I'm in awe that you have a PhD. But the day then, and a lot of people today say it's the fat that's causing the inflammation, when you pretty much showed that it was the sugar causing the inflammation.
Absolutely. And by the way, not only did we show the sugar damaging the vascular endothelium, when we put whole blood through these livers, but we added a sugar concentration, we immediately created fatty liver. So, and we could see these little globules. So fatty liver is not a disease of fat coming to the liver. Fatty liver disease is a production of fat by the liver as it tries to. So you first glycogenate. So you first deposit sugar as glycogen, and we could do that within 3 hours of perfusate. But very rapidly, the liver starts turning sugar into triglycerides. And so fatty liver by itself is just the conversion of sugar to fat. It's a benign process. But when you add a higher concentration of sugar, you're getting the sinusoidal inflammation together with the fatty liver, and that's steatohepatitis, or inflammation of the liver. So if you've got fatty liver plus inflammation, that's the devastating injury.
What's tragic is I've treated at Duke people who've had a liver transplant, and the liver is becoming fatty again, even the transplanted liver, and no one has told them not to eat carbohydrates.
And then you add to that steroids for immunosuppression, it's not a pretty picture.
And so, but what you found is that even the steroid suppression isn't very powerful.
No, not at all. But the point I'm making is that we in the 1990s understood fatty liver disease. Now you've got these companies making T3 receptor agonists and selling that, going through the FDA. Resmetirom, I think is what it's called, as a T3 blocker. The problem is when you block T3, now T3 is part of the cholesterol production pathway. So now you're seeing all these cholesterol, not that I'm worried about it, but you're seeing a cholesterol in the thousands total. So again, I mean, because we are unable to accept the fact that sugar causes damage, we go down all these other pathways, and lots of money involved.
And so I guess to summarize that, you knew this a long time ago, and that it was sugar that was causing the inflammation, and fructose, glucose in kind of a priority, and that it wasn't fat. And
Correct.
it went against the teaching of the day. I mean, did you get this published eventually?
Well, it's published in my PhD, but with a lot of caveats, because I was being dishonest. I was lying about my data if I said what I've just said to you, because it was so unbelievable.
It was even stronger than that.
Exactly
Yeah.
right. So
Well,
I had to
so
be very cautious about how we talked about this.
so someone would have to go to the university library to get your PhD published on the wall. It never made it into a peer-reviewed
Yeah,
publication.
well, some of the minor papers made it into peer review, but the big stuff. I'll give you an example of kind of how crazy this is. Probably one of the best ketogenic papers I've read in a long time was done by a young woman called Isabella Cooper in the UK. And Isabella's a PhD student, and she went 2 years ago to the IRB, and she said, "Well, what we're going to do is we're going to take a bunch of people on the standard UK diet, the Eat Well diet, and we're going to put them on a ketogenic diet and study the changes." Because she believed that would improve things. She couldn't get it through IRB because she was going to harm her subjects. So then she flipped it around and she said, let's take people already fat adapted on a ketogenic diet and put them on a standard diet, because we're taking very sick people and making them better with a standard diet. And then she proved with the blood work that that was a problem. But same thing for me is, we just couldn't get that through the roadblocks of people's cognitive dissonance.
Well, and
Now,
which now with the 20, 30-year perspective that we have, it occurs to me that we all go into nutritional ketosis if we don't eat for 2 days. In fact, people who say that it's terrible and you're killing yourself will be very happy that they're able to have nutritional ketosis if they can't eat for 2 days. So to me, it's even like the safe mode. It's going to be like when they
well, let me stop you for a second there, Eric. Very, very few people can go 4 hours without eating, let alone 2 days.
well, well, I know I've been in front of audiences and I said, how many of you ever gone a day without eating? And rare. But I mean, they can. It's just that they're hungry and the food is everywhere, right?
They're miserable. Yeah.
I often bring up these reality shows where people on their own volition go out to the middle of nowhere. I mean, anyway, the fat adapted eating low carb, high fat diet is actually a natural thing. We all do it, and yet it was only kind of this year when I heard Jeff Volek speak. Again, he's been studying this as long as you have and I have, and well, you've studied this longer than I. It was about the year 2000 when I started looking into this. And he basically said this year, there's no evidence that a low carb diet causes harm. And when you look back,
I would be even stronger with that. I would tell you that a low carb diet optimizes human
well,
biology.
yeah, but that's kind of extreme. I'm just
There's
joking.
extreme out there,
Not
right?
extreme. Well,
But
but
let's flip it around, Eric, because the other thing that happened to me when I was in the laboratory, especially my last year of PhD, where I was starting to do some surgery, take some call, very stressful. I also quit playing sport. I gained 100 pounds in a year. And I can assure you, it wasn't because I ate too much fat. The other part that I could correlate, you asked me the question, what I was eating, my diet went up to about 80 to 90% of carbohydrates, and I ate continuously. So it would be the muffin, it would be the M&Ms, it would be, so it was a continuum of eating, little bits here, little bits there, like a smoker, and it was almost all sugar and starch, whether it was healthy fruit or unhealthy muffins. I mean, sugar is sugar by the time it enters your
be
bloodstream,
close
but you
health
understand,
fruits.
yeah. Remember this, that what enters your mouth is outside your body. It's only when it transitions across the gut that it enters your body. And whiskey doesn't enter your body, alcohol does. Apples don't enter your body, sugar does. So you know that. But
No, that's great way to put it. Well, so I had forgotten you had a personal experience with weight loss. Did you use a low carb diet to lose weight then?
no, not at all. No, so I gained that 100 pounds very readily. So my body, if I don't socially distance from a donut, I'm gaining 5 pounds. I'm very, very effective at gaining weight. And then after my surgical training, I went to Vanderbilt. So this is now 5, 6, 7 years later. And I was appointed as a pediatric surgeon at Vanderbilt, my first real job. And one of my first patients was this young 13, 14-year-old African-American kid who weighed between 350 and 400 pounds. And I was taking his gallbladder out. And everybody, oh, you mustn't eat so much fat. You got to see the dietitian. And, the balance, don't eat fat, low fat, more grains, more fruit. And I walked into this kid's room and all of his family was sitting there. They were all enormous. They were all kind of my size or a lot bigger. And they weren't gathered around sticks of butter. They were gathered around, again, just like my own diet. 90% of what they were eating was sugar and starch and what they were drinking. And I realized, I mean, that was the culmination for me, my own journey, my journey in the laboratory, my journey with my patients. I realized two things. Number one, it's sugar, not fat that we're eating, not that making us fat. Number two is, as a surgeon, I am very good at taking this kid's gallbladder out, but I'm useless at helping him with his obesity. There was a moratorium on bariatric surgery at the time in adolescence. And I said, I want to be able to help him with the core of what he's doing. And as I started to get into bariatric surgery, it's by far, the best way to lose weight. I can guarantee you're going to lose weight after bariatric surgery, but 85% of the patients gain their weight back or become metabolic train wrecks because they don't change the behavior that caused the obesity in the first place. And when I started to look at my patients, my successful and unsuccessful patients with surgery, they all lost weight, but what differentiated recidivism? And that was a return to snacking and a return to carbohydrates. And then I looked at the diet that we were putting them, and I said, if I was to design, and I can tell you this now, the ideal diet to make someone fat after surgery, it's the very diet we put them on post-operatively. Multiple small meals, soft foods, mashed potatoes, grits, yogurt, smoothies, protein shakes. And they're consuming these little bits regularly because they can't eat a lot at any one time. And they still lose weight in the first year. But if they keep those habits, they beat the surgery. So the sad part is my surgical colleagues are excellent at getting people to lose weight, but they're also excellent at teaching them how to fail.
So may I shade the language just a little bit that while it may be the most certain way to lose weight,
Yes.
it may not be the best way. I mean, the obesity medicine doctors, the medical group, we criticize the surgeons, well, because it is so effective, but many people lose muscle mass because they're not eating enough protein.
But you see, that's not a surgical problem, just like with Ozempic. That's not an Ozempic problem. That's a diet problem. When my Ozempic patients, my surgical patients are dominant in protein, and that's my job. I don't like the word protein, but animal products, they don't have that muscle wasting. So,
but they need the proper coaching.
oh, exactly right. It's a partnership. But when you outsource to surgery and you don't change anything, of course that happens.
You know, I'm a medical guy, so years ago, surgery is just awesome. I mean, I loved every minute I was on a surgical rotation, but I wasn't for me. It's just a little too harsh. I mean, even today, I'm chatting with a family friend, and one of her friends had the Roux-en-Y gastric bypass, where the stomach's made about the size of a hen's egg, and then
you see, Eric, that's not the issue. The issue that you're sewing their butt to their mouth. So it's the metabolic part is the problem, where it's the malabsorption of the metabolic surgery. I don't do bypass or do duodenal stitch.
Well, but just I was trying to
right. No, I hear you.
Demonstrate the risk, or so she was told not to have carbonation because you can actually expand that little pouch, but she didn't hear it or didn't notice it. She had a beer. And so she didn't have a carbonated soda or anything, but had a beer and ruptured the pouch and had an acute abdomen and died. I mean, this is just a few weeks after the surgery. And I'm like, wait a second, you're worried about a keto diet? And yet now you're saying, surgery is a free pass? I mean, so it's a big deal, although sure, it's very effective. And but
let me correct one thing about the beer, though. That wasn't the beer that did that. That was a surgical staple line failure.
Well, right. Well,
that is a technical, right. That would have happened if she'd eaten a piece of steak, a lettuce leaf. That was a technical issue with the surgery, not the beer. Because I don't stop any of my patients from drinking carbonated fluids.
Interesting.
Not at all, because the pouch is what it is, and the integrity of the pouch is the issue.
Well, and then it's surgeon dependent. Right?
Exactly right.
So anyway, I'm not a surgeon, but now just how, although I've learned that there's some people I can't help. In fact, it was the kind of like your early experience in Tennessee. I see some people in North Carolina, they grow up heavy, They come to my office when they're 30 years old, they weigh 500 pounds. A medical program, in my experience, even medication just isn't strong enough. So I think there is a role for weight loss surgery. And how do you, let's say someone comes to you, how do you discuss all the different modalities you have?
Well, I think the important thing, whether we're talking about GLP-1s, which are, in my opinion, wonderful drugs, when
So
they
Ozempic, but we just have,
yeah,
isn't it?
Ozempic or Wegovy or Manjaro, so the GLP-1s or Ozempic and surgery kind of are the same. Is that when you outsource to them to solve your problem, you're going to fail. A little bit like an antidepressant. You put someone on Wellbutrin or Prozac and you expect their depression to go away. No. They establish a foundation of weight loss, but you have to partner with them, and your and my responsibility, whether it's Ozempic or surgery, is to educate and train that patient beforehand. Plus, you're not going to change afterwards. When you're losing weight magically, there's no incentive to change. So what I do in my practice is I set them up, say, okay, let's put surgery on the table. We're going to put it there in 6 months' time. And I want you between now and then to bust your butt. And if you're successful, we'll keep postponing the surgery. Because remember, as a fat guy, I personally planned to have surgery. I gave myself 4 months. I topped out at 300 pounds, BMI of just over 40. And I said, look, at the end of this year, I do not want to be fat. I don't care what it takes. That's my priority. And I was an expert, like so many of my patients, I was an expert at failing weight loss programs. I was really good at beating Weight Watchers and the others, could lose weight, but gain it all back. So I said, I'm going to put surgery on the table. Now I would put the Ozempic on the table. But you start by changing your eating pattern. And then if you need assistance beyond that, then of course you do it. So you crumple up the cigarettes, you throw them away. And if you failed a few times, you take Chantix to help you to do better the next time. You don't just shake Chantix and help you and expect to quit smoking. So same thing here. And I think the issue is not the drug or the surgery. The issue is we providers are not managing that relationship effectively. And most of us don't understand that part. So both of those, surgery and Ozempic, are great when used appropriately as transitions. So nobody should be on Ozempic forever. It's a transitional drug, just like methadone. But I've seen people who have been on methadone for 10 years. That's a problem for me because they haven't changed. Or you're vaping now. You're vaping to quit smoking, but you've been vaping for 10 years. That's a problem. There's no difference to me than, and it loses its effectiveness. GLP-1s, oh, I had somebody this morning. GLP-1s, it stopped working. No, it didn't. You didn't change. And sometimes we have to coach people and help them to continue to change.
Well, you can just kind of imagine if you have a hormone, you give more of the hormone, you're going to develop the hormone resistance. There's going to be
Absolutely.
a GLP-1.
And you develop GLP resistance.
Yeah. Well, so how did you get into the carb addiction? And there are very few doctors who really talk about addiction as explicitly as you and I do. How did that happen?
I think the first thing is I'm a surgeon, so we have a higher threshold for skin thickness. In other words, when I was able to see this so obviously, I was more comfortable talking about it and putting it into practice, even though it created a great deal of risk to me. Because as you've seen with other folks who've gone down this pathway, Tim Noakes, Gary Fettke, a few others, they've been crucified for taking a stand. And I was willing to take that because of my own journey. And I have imposter syndrome, terrible imposter syndrome, which means that I cannot believe, even to this day, after 25 years and tens of thousands of patients, I cannot believe that I'm right. So it's with trepidation that I talk about what I'm talking about, because everybody out there, all the experts must be right. How can I be right? How can I be the only one in the platoon that's in step? So, but the beauty is every one of my patients reiterated that I was right. And their results every day prove that I'm right. I'm working with Dexcom right now, and it's incongruous for folks like Dexcom and all the endocrinologists to believe or to understand that type 2 diabetes you can put into remission. No, it's not possible. So what happened with me is I saw very clearly who was doing well and who was doing poorly. And the beauty about surgery, things happen very rapidly. You lose 100 pounds in a year. So I can tell based on that, why isn't this person losing weight as fast as everybody else? And you look at what they're eating, and we saw our patients regularly. Actually, that was one of the beauties. I got involved with this with the lap band, and I loved the lap band then. And the reason for that is because when patients were struggling, they would come to you for an adjustment of the band. Whereas when they're struggling with a sleeve, there's no way on God's earth I'm going to go to my doctor and get beaten up. So while they wanted an adjustment to their band, I was able to get in their head and understand what they were doing. And it was always snacking and sloppy carbohydrates or drinking them. It was always the same when they were struggling. So very rapidly, with the volume of patients I was seeing, it became so obvious observationally that I was able to address that side of things in my own life as well as with my patients. And I was fortunate to be surrounded by incredible people, incredible psychologists, a weight loss coach, clinical nurse specialists, a dietitian who could see this, who weren't just the balanced, eat a little bit of this and a little bit of this dietitian. He said, no, look at what you're eating here. You're fat because of that. Can we let that go? So it wasn't me, but my team supported me in understanding that. And when they watched me eat and they watched me hiding M&Ms in my drawer and my Coke in my office, it was so obvious, Eric. It's so obvious.
Well,
And,
addiction, you can be in denial, you can steal, you know. Well, can you describe what the lap band was? How do you?
yeah, so the lap band is handy dandy. It's a
Thank
little
you.
device that goes around the top of the stomach, and it's got a little balloon on the inside. So with this port, you can tighten or loosen the band. So instead of having this whole thing as your stomach, you've now just got this little piece. You eat a tiny amount. If the band is properly adjusted, it sits there and then it slowly goes through. Well, if you're eating ice cream, it does nothing.
Right.
And
You could drink through this. Like,
you can eat your way by snacking and eating your way through it. You can defeat the device very easily. Now we can tighten it up and bump you forward. But the lap band was great for a long time, but it developed so many complications, primarily failure, because people were just slapping them into folks and expecting them to lose weight.
yeah.
And now we see esophageal dilation, we see problems with it. I still love the lap band, but it's come and gone as a feature because it was so mismanaged and the reputation has been tarnished. And one of the things about bariatric surgery is because we struggle to keep people's weight off, we just went to more and more radical surgeries. We went to gastric bypass. We went to SADI, which is basically that's why I talk about sewing your mouth to your butt. And you can eat whatever you want to, but you just poop it all out. So you lose a lot of weight, but you become malnourished. I end up reversing many of those surgeries. So now the other piece, even if you just buy into the calories in, calories out narrative, which most of my colleagues still believe in when it comes to surgery, you have to if you're going to reduce caloric consumption. But now what they're doing is they're doing surgery and adding GLP-1s. So, and what they're able to do is do a lesser of a surgery, maybe a sleeve gastrectomy, and
Mhm.
immediately add the GLP-1. So there's synergy, but still there's failure over time. So ultimately, and the challenge is there's no incentive for a surgeon to change their thinking because they never see their patients down the road. Most of
Well,
my patients that come to me after surgery can't even remember the name of the surgeon that did it. And you don't fail tomorrow. You fail at 4 or 5 years, you start to
yeah.
see that weight coming back. So
We try organizationally, the Obesity Medicine Association, which is the medical group, and I'm past president of that group. We've tried to connect the surgeons with the medical, and it's just they're very siloed. And I remember seeing ECU, Walter Porres here in North Carolina, East Carolina University. He created the Roux-en-Y. And he explained that it wasn't too strong, but it still worked. It was right in the middle. But then we were at a CME program for family practitioners, and he basically said, I need your help to take care of these people because, we can't follow them. And I looked at him like, no, really, you're opening this Pandora's box. And it seemed a little irresponsible to me that you would do an operation and then never follow them again. But, that's the way the world is, I guess,
Well, and you see, that's the thing, is that most surgeons believe, and again, I am a surgeon, I love what I do, but I love the management as much, if not more, than the surgery. In fact,
Yeah.
I do the surgery as fun for me. It's my little enjoyment. And then the management is the hard work, but the enjoyable hard work is you help your patients, because that really is an understanding. And but at the same time, most surgeons are happiest and best in the operating room. They're there because they don't manage patients. So I don't condemn it, I don't demonize it, but I think we can all do better. I think the physicians can incorporate other strategies. Now they're being forced to make decisions about GLP-1s, but the surgeons can also expand this. The way I look at it is you can change a flat tire every day, but until you pick up the nails at the bottom of your driveway, you're not changing why you gained the flat tire in the first place. So that is what I discovered. And I looked at myself and I looked at my patients, and I realized this was no different than treating an alcoholic, treating a heroin addict. We were dealing with this as from a substance abuse perspective, not a nutritional perspective. So yes, nutrition, you can survive on a low carbohydrate or a non-carbohydrate diet. But ultimately, every drug that you take, you have to be able to survive in abstinence. You don't die of dehydration. Or at least let me put it this way. If you quit drinking, you would die of dehydration. But you don't die of dehydration if you quit drinking alcohol. And nobody loves to nobody tells alcoholics what they should drink, but everybody loves to tell fat people what they should eat. And that's a mistake as well. The default is you're going to do pretty darn well, whether you go vegan or carnivore, if you're not eating carbohydrates. And I know we can talk about vegan and carnivores, which is better and worse, but ultimately it's about carbohydrates that cause the majority of the illnesses. Then on the vegan side, I think you've got micronutrient deficiencies. On the carnivore side, you got macronutrient excess, which is a problem as well in the carnivore side. We can go down that rabbit hole. But
yeah, well, so let's say someone wants to use a diet, so it'll take you out of the surgical suite. And
yeah,
how do you look at different diets? And there's a lot in common between a vegan and a low carb keto or carnivore diet, and that's the absence of junk food, right?
correct.
So actually the Stanford study, Lucia Ronica looked at the people at the extremes in one of their studies, when people who said they were doing the Ornish like, the others doing the Atkins like, and the effect on insulin resistance was very similar. So I think it's a false choice to say only those. So you have the history with David Jenkins and the group with low glycemic diets, learning that inflammation comes from sugar. Is that how you got onto low carb diets then?
I think it was really just looking at myself, looking at my patients to understand what the problem was, and also not just to understand the problem from a concentration perspective, but most doctors, when they're talking diet, they're changing what you eat. And I realized this had nothing to do with what, it had to do with why. I'm on my way home to dinner. Why am I stopping at McDonald's for McFlurry? That has nothing to do with nutrition. That has to do with emotional restitution after a long, hard day. Just like coming home and having a shot of whiskey, I'm having the McFlurry. And I realized that all the things I was doing that were causing me harm had enormous beneficial potential as an anxiolytic. Not just, but when I was depressed, I was eating. When I was bored, I was eating. And it wasn't steak or pepperoni and cheese. It was sugar and starch that was driving every aspect of my emotional restitution. The other thing also, Eric, and you know this, as we get busier and as we have families and people take away our time, or we allow our time to be taken away, we have less time for self-care that takes effort and time. It takes an hour to go to a gym, but it takes 10 seconds to wolf down some ice cream or to drink a Coke. So we develop an instant gratification approach, whether it's a cigarette, an some alcohol, a Percocet, or an ice cream, as an instant massive relief of emotional tension that doesn't take away from our time, that's readily available for us. Now it's frowned upon to be sitting there with a cigarette. You're old enough to understand that 40 years ago, you and I, well, I didn't smoke. I don't know if you did, but smoking
Well,
was the thing of the day.
my
And
parents did.
right. So,
We would be on this video smoking.
right.
It's
And,
crazy.
even as a medical student, we would go on rounds, and after every ward, we would stop for a smoke break. I didn't smoke, but now we stop for a donut break. So the narrative has changed. The behavior is identical. The drug has just changed. But the behavior pattern is no different. And I'll tell you this, you may be old enough, I'm not, but pre-1910, the reason prohibition happened was not magically. It happened because people were overusing gin and alcohol as a societal form of emotion management. So we went to the radical step of prohibition. Now we still have alcoholism, but I think prohibition curbed that to a large extent and created a moratorium, changed our societal approach to favor alcohol against alcohol. Big tobacco, we changed our approach to favor nicotine, where doctors said, it's a great anxiolytic, no harm here. And we switched. Now we're saying that these sugars and starches, the whole grains and the sugars are so healthy for you, nothing to see here. But we're doing the same thing with marijuana. We're doing the same thing with vaping, driven by industry, not driven by health.
Yeah, so do you, so in my practice, I learned from a lot of the doctors around 1995 to 2000 in that era, and I do pretty much 20 total carbs or less. It's a total carb cessation. It's a cold turkey, pun intended, sort of approach with getting all the sugars and starches out. Some people then say it's keto because you do get the nutritional ketosis. How do you start someone out in and I have to say, I do it kind of one size fits all. I say, you want this to work the first time every time, or should we diddle around and try something that might work? And most people will say, well, I want to try the one that will work the first time, the keto level. But how do you look at the diet in
I think
keto?
the first step, when you're looking at this from an addiction perspective, when you're looking at it from a diet perspective, today's day one, here's your diet, off you go. And you're jumping into the deep end of a pool without knowing how to swim. When you look at positive change with addiction, there's a group called Prochaska that wrote a seminal book called Changing for Good about smoking and about the process by which people successfully change with smoking. And the first step is just going from a defensive pre-contemplation to a contemplation of liability, harm, and perhaps I could imagine myself beginning to change. The contemplative phase then goes to the preparation phase, to the how am I going to do this practically? Then you go into action, and then you've got to keep moving forward because you've got to be aware of relapses. So understanding that when I first see somebody, depending on how they come in, whether they're pre-contemplative or contemplative, already on the journey and they just need some direction, I've got to know that person as an individual. And one of the little side effect here is that more and more healthcare has become a singular algorithm of best practice that we plug everybody into. But I want to know, and I was trained to treat you as an individual where you are, not where I would have you. So I've got to get to know my patients first, meet them where they are, at what stage of change are they, and then help them to initiate it from there. So my job with my patients is to reinforce good behavior and help them to alter behavior patterns that can be improved. Not, this is bad, you can't eat this, you mustn't eat that. I want them to choose not to eat ice cream rather than think of ice cream as being bad. So in the addiction world, it's all about empowerment and about choice, knowing that nobody ever quits the first time. Nobody ever quits the first time. And we build in not only the concept of relapse, but how to recover from a relapse. Because you only fail when you quit, but you will relapse. And I'm 24 years in, I am not perfect. I still make mistakes. I've got a plan for owning my mistake, which is where the binary nature comes in, for owning my mistake, for analyzing why it happened and not undoing it. I can't go backwards and pay it backwards, but for making sure that the next time I'm in the same situation, I'm not going to repeat it. So we arm our patients with tools rather than just a diet sheet. The other piece also, I know that you are, and I'm so impressed with this, an Atkins acolyte, but we no longer talk about the Atkins diet, despite the fact that everybody did really well in terms of weight loss. But the reason they failed, why Atkins failed, and not Dr. Atkins, but the diet, is because people lost a ton of weight, but then they regained it back because they didn't replace the emotional role of carbohydrates with something else. So in addiction management, the only person that can quit drinking alcohol is the person themselves. It's a very lonely thing to do. AA is there to help to rebuild the person with new skills, new tools from an emotion management perspective to replace the singular role that alcohol had. And our program is as much built around the replacement, the emotion management strategies. I call it chess, the creative arts, the human connection, the physical activity or exercise, the spirituality or meditation, and the healthy sexuality, healthy sleep. That has to become a fundamental, intentional. You got to intentionally force yourself to participate in those until they become part of who you are. But if you don't have a replacement, you're going to relapse every time life throws a curveball at you. And if you don't walk your dog every day, you're not going to walk your dog on a bad day. You're going to go back to the fridge. The other
Yeah.
part that I also talk about, Eric, is that if you take your current age and you subtract it from 100, let's assume you're going to live to 100. That's how long this has to last for. Most diets last a few weeks. Okay, I lost 10 pounds, I lost 20 pounds, my diabetes in remission, even a year or two. That's a tiny fraction of forever.
So your mentioning of the Atkins diet and the perception of that made me think. I haven't worked with the company. There is Atkins. Well, no, I think they got purchased. Now it's Simply Good Food. Now they would have you just eat their products forever as the long-term goal, and now they're keto products. Keto ice cream and all. What is your take on all these aids to follow low-carb diets?
Well, I think they're absolutely fine as an early shift, but if you look at my program, I do things incrementally. So we start with little. I want people to be a tortoise, not a rabbit. A diet is a rabbit where you do it all at once and then you crash and burn. Tortoise is you make slow removal replacement changes by category. And getting rid of what I call lookalikes is the last stage of that. So it's stage 4 or 5 in my program. And the lookalikes means what it's made of is healthy, but why I'm eating it is still a reminder of the old. So I'm eating a keto pizza, I'm eating keto brownies, I'm eating keto ice cream. And those are eventually things that are on the no list. And the challenge with the Atkins products is I don't think, and you're more expert at this than I, they defy Dr. Atkins's dietary approach because he was changing what you were eating. He wasn't making all these manufactured lookalikes.
Right.
And the manufactured lookalikes are just permission to eat something that reminds you of the old. It's like having a light beer or a light cigarette. How good is that for the alcoholic or the smoker?
Yeah, not good at all. Yeah, so at first I'm using sugar-free alternatives, so anything sweet but not sugar, kind of to get people off the substance, and then over time whittling it away. Some people though transition and then they never really want the sweet again. Others it's a slower burn, like you're saying. That great. Well, and do you find that in your program that well, I guess describe how you do it. Are you're seeing people locally? You see people remotely? Well, what if someone wanted to see you as a practitioner?
Let me just slide back to just what you were saying there just before this, and then I'll answer that question, is that the concept of artificial sweeteners, I like the way you use them. Artificial sweeteners are a bridge away from real sugar. However, there are two types of people. Some are able, like my wife, to use artificial sweeteners so that she doesn't drink the real thing. She'll have a Diet Coke so she doesn't drink the Coke. There are other people, and Tim Noakes is quite famous for this, that finds that when they do eat anything sweet, it's a trigger for the wrong thing. So they purposefully don't use the artificial sweeteners. And that's one of the reasons I chose coffee. This is coffee. I'm sipping on it throughout the day. This has nothing to do with hydration. This has to do with, I call it a mind cleansing moment, a little emotional restitution when I'm talking, just like I talk with my hands a lot. So those are anxiolytics for me that don't cause harm or very, very little harm. But the artificial sweeteners have benefit or liability depending on who you are as a transition. In terms of what was the question that you asked me in terms?
How would someone see you in
Yeah,
person?
so things have changed dramatically, and I think probably in your practice as well since COVID, when we open up telehealth. So I see patients anywhere in the world, and we could do it telephonically, by WhatsApp, or by Zoom. Those are my metrics. And the beauty about my practice, Eric, is there are enough people out there who are now aware of and trying to do a lower carbohydrate approach, whether it's diet or addiction or whatever it is, or got health issues to resolve. And so few of us, that my almost all of my practice, 90% of my practice, is self-referral by people who've already decided that they want to do this. Whether I just saw a patient now with horrible Crohn's, and she'd heard about a carnivore approach to Crohn's disease. Where it's someone with type 2 diabetes, saw another one this morning with an A1C of 12.6, and the doctor's telling to eat a lot of carbohydrates. And she realized, no, so they're coming to us but they're already motivated to change. They need guidance. They need blood work. They need guidance. And so I'm in the luxurious position of very few of my patients coming in that I have to convince that they must change. Or I've got a carnivore who's seeing their A1C going up. Why is my A1C going up when I'm just eating tons of protein? So I'm able to troubleshoot at a higher level. I would struggle with my program to take people off the street and say, hey, you're fat, you're diabetic, come in and see me, I'm going to help you. Because they're pre-contemplative to that. I see a few like that. And the ones I struggle the most with are the anorexics. The anorexics and the bulimics, because they run instead of trying to fix the problem. So that's an area that we've got some expertise with. So it's not just the excessive eaters, it's the under-eaters, which are the opposite side of the same coin. But I see patients from all over the world. They access us, and then I've got a dietitian, a mental health worker. We enroll them in that program, and not everybody has to see the dietitian. Some people just need a little tweak. Some people need more blood work done. So we individualize therapy. We individualize change. And my job is to arm you with enough information and enough equipment that you become the single best expert on your own life. That you are a better expert on you than I am on you. I have the knowledge, but you know you. And I help you to see where you're hiding certain things, where you're distorting reality to yourself. So there's a reality check. But I consider our program to be a little bit like AA for fat people, where you're doing great. You've been sober for 2 years, but you still come in for a meeting every now and then just to see what's new, just to reinforce with humility the pathway that you're on. Or you come in to show off. I'm good with that.
And you have time to put together scholarly works your talks at the meetings I go to are always great. And you contributed to the textbook called Ketogenic, Tim Noakes's book. You had some chapters, was on autism?
Autism spectrum disorder, and brain structure. And yeah, I've got a 3-year-old son, so it's pertinent to that. But as a pediatric surgeon, I also, and of long standing, I've also seen this massive exponential increase in autism spectrum disorder that defies any of the current reasons why it's a problem. We've debunked completely the vaccine issue. That's been debunked as a lie for a long time. But now the narrative is that it's spontaneous genetic mutations, and billions of dollars have been spent on that. And yet there's no consensus. There may be about 5 to 10% that are new mutations. But even if it was a genetic mutation, a spontaneous, there's no way that you go from 1 in 15,000 in 1970 to a low estimate of 1 in 32 by the CDC last year, 2 years ago. And that rise is just too quick for this to be genetic. But it's so obvious. When my 3-year-old son goes to preschool, and I sit and I watch what they're eating, and he opens his lunchbox, and 95% of it is meat. And the other kids open their lunchbox, and it's healthy Go-Gurts, healthy yogurts. It's a healthy slice of apple with a little bit of honey to dip it in. It's like, where's the meat? Where's the fat? And then the little granola bar, because it's a healthy granola bar, or the gummies, or the little piece of cheesecake. That is what's in these. I literally looked at a class of, I think it was 14 kids the other day, And I just looked over and peered over their shoulders. They opened their lunchboxes. And I would be dead of malnutrition and starvation because I'm carnivore if I had to eat what was in their lunchboxes. It's just quite incredible. And these are 3-year-old kids. Now, the human brain continues to develop for the first 5 years of our lives. And the brain is mostly fat. And if there's no fat in your diet, now you can convert sugar to fat, but the quality is very poor. So it's the little three pigs. When we build our house of straw and sticks, it doesn't work so well. When you build your brain of carbohydrates, it doesn't work so good. If you build it of bricks, it's going to be, if bricks are your foundation, it's going to be a much better brain. And autism spectrum disorder, bizarrely, is purely by DSM-5 criteria. It's purely an observational disorder. Mm. But you can tell on MRI at 3 to 4 months of age whether a child has the structural changes to the white matter that are consistent with a diagnosis of ASD, autism spectrum disorder. But we fail to recognize it's a structural disorder. So if we fail to recognize the structure of the white matter, then we have to wait till the child's 7 or 8 years old before we make the diagnosis. And at that age, it's too late.
So are there any, I know there's some anecdotal stories about people getting better on a low carb or keto or carnivore. Is there any clinical research, or do you know anyone who's studying autism as an outcome using the diet that we use?
No, not well. There are people out there that are using a higher fat keto. The only place in pediatrics where a ketogenic diet is almost universally acceptable is for intractable seizure disorder, epilepsy. Yeah. And we know spectacular results with that. Everywhere else, it's questionable, but a lot of the people that work in the epilepsy space will cross over to the ASD space. And what they use, in fact, the guy that first described, I think his name was Weinberger, if I remember correctly, but the guy that first described ADD, ADHD said that my disease would not exist if sugar didn't exist. But we're medicating everybody instead of putting them in therapy. So the place where you can help an autistic child is because they have a lot of sensory issues, they have to eat or they prefer to eat a specific consistency with food, which is usually a very smooth consistency, which you get from carbohydrates. You don't get so much from steak or broccoli. We're dealing with all those side issues, and it's a tremendous challenge for the parents of these kids. But they often use a low carbohydrate approach to decrease the hyperactivity of these children. But it doesn't fix the structural damage that gets done in the first 5 years, in utero, in the first 5 years of structural development of the brain. That's fixed, that's permanent. But you can modify some of the behavior by changing the diet.
Do you mind explaining, so what does your family eat? You mentioned carnivore and your son was eating meat at school.
So we live in Florida where DCF, the Department of Children and Families, is very dominant. And I don't want my son taken away from me because I'm killing him with his diet. But everybody knows that gluten is really bad if you have a gluten sensitivity. You're a gastroenterologist, you know celiac disease. And what is the treatment for celiac disease? No carbohydrates, no grain products, at least. Right. So my child has celiac disease. And therefore, we feed him, and he likes meat because he says meat makes muscles, and he'll show you. So he likes meat. He doesn't like vegetables very much, like so many kids. So we feed him.
No, but that's the parents' job to get their children to eat their vegetables.
We try so hard, Eric, but he throws them on the ground. And so he says sour and he throws it out. But you give him a piece of bacon, you give him a piece of steak, he'll destroy that. So that's his preference. I'll tell you something very funny. At Easter time now, he went to an Easter egg hunt place, and he opened his little Easter egg, and there was a Tootsie Roll in it. Now, he's never eaten a Tootsie Roll. So he opened this thing, and he said, "Oh, sausage." And we said, "No, not sausage." Took it away. Funny. But he actually had a lick of the thing, and he said, "Oh, sour," and he threw it away. So he's conditioned that way. But that's because he doesn't like vegetables, and he doesn't like, he's not allowed to eat grain products because it's very inflammatory for his gut. So he's primarily, by default, eating about 95% of his diet as meat. And if you want to know what we eat as a family, if you're on Instagram, my wife has a page called Carb Addiction Mom, and she posts photographs of what we eat. So it's on there. Uh,
Fantastic.
but yeah, so you know, I personally am mostly carnivore. I'm also about 95% carnivore by choice. I eat vegetables when we go out. We don't typically eat them at home, primarily because I got sick and tired, not because it's better or healthier, but because I don't like throwing out dead vegetables at the end of the week, and my dog won't eat a leftover salad, but he will eat leftover steak, or he won't ever get steak, but he'll eat leftover animal products.
Have you
But
gotten into the fine art of eating pork rinds?
I
Chicharron?
don't. My son does. He loves those are his chips. He loves them. So
It's
I've tried.
not.
So you know, in my own life, Eric, because I've got a problem with carbohydrates we've talked about, I try not to do the lookalikes. But when my wife and my son are together, they'll have chuffles, they'll have the pork rinds, they'll make eggs and cheese into a tortilla. It's the ingredients are good. What they're eating is not carbohydrate, but I'm not going to eat a chuffle because it's too triggering for me. And I'm trying to get away from that concept. So again, I'm different than they are. I don't have that propensity for it. But at least they don't have the propensity for nth degree behavior. I do. And
Well,
so I'm going to be just a little bit cautious about that.
as usual, we talked and talked, talked, and time has run out. How do people find you?
So we've established a single number that people can access us from all over the world. And it's our bat phone. It's a cell phone that's got text, it's got WhatsApp, and it's got email, and it's got phone calls. The number is no matter where you are in the world, US area code 1-561-517-0642. And that's the entry into our practice. You don't need a referral. You don't need to have a family doctor. A lot of our patients, as you know, are at loggerheads with their family practice. The beauty is you can set up a visit directly with us. The sad part, Eric, is that because of the time we spend with our patients, typically an hour for the first visit, half an hour for follow-ups, I chose at the beginning of this year to radically decrease the insurance I'm taking because to get paid $27 by Medicare for an hour-long visit, I try to hold on for as long as possible. But this year, Medicare decreased our payments by 2.6% and made it more difficult for us to extract money. So unfortunately, we are really not taking a lot of commercial insurance. And that's a tragedy. But the reality is you've got to see 20 patients in an hour at 5 to 10 minute slots. I can't do that.
Yeah, but that's great that you're doing it. And thank you so much for spending time. My people are Adapt Your Life Academy ALA membership group. They'll watch this first, and then it'll go out onto Adapt Your Life YouTube channel. And again, just a pleasure to talk to you. I can't wait till we get together again and scheme to save the world yet again. And
But you know, Eric, there are not many people in the space that I look up to as mentors. There's about 2 or 3 folks in the space that I look up to, and you're one of those. You are way
well,
up there in terms of what you do well. I have the utmost respect for you, especially with what happened in Ottawa, which I think about often. You have no compunction about calling people out when they're FOS. And I
well,
really appreciate what you've done, and you are so solid with your information.
well, there is a follow-up. Well, thank you for your kind words. There's a follow-up. Someone is sending me crystals to see if they're coming out of the skin. So we learn, we live and we learn, and but we do have to kind of self-police a little
Of
bit.
course we do. Of
Yeah.
course. And I think that is we've got to be inquisitive. And I look at oxalates more from the calcium malnutrition perspective than from the problem of oxalates. But,
Yeah.
even in our space, we're over-focused on protein and still under-focused on fat.
Yeah.
So
Well,
there's a lot of those little questions that we can continue to ask. And that's what you do is you're inquisitive all the time and you adapt and you move forward. And I love that.
well, and you are too. And I'll have you on again, okay?
Thanks so much, Eric. I appreciate this.
Bye now. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.